Ladies and gentlemen, we've reached the last session of this Congress, and I present to you Dr. Peter Canellos. You all know Peter by now. He's a practitioner in the Johannesburg, Pretoria area, qualified in sedation, got a DA, and Peter is the current secretary of SOSPOSA. He will talk to us about the approach to the diabetic patient presenting for sedation. Peter, all yours.
Good. Thank you, Reinhard, for those kind words, and welcome everybody. So, after we've all had our tea and our sugar rush, it's time to talk about a diabetic patient and sedations. I was asked to speak about the diabetic patient presenting for dental work, so I've just altered it a little bit, because basically everything is basically similar. So we start off with some definitions, as always. Diabetes mellitus is a group of metabolic diseases characterized by hyperglycemia, resulting in by either insulin secretion defects or insulin secretion and could be an action or both. Type 1 diabetes is formerly known as insulin-dependent diabetes and is characterized by beta cell destruction caused by autoimmune process leading to absolute insulin deficiency. Type 2 diabetes, previously called non-insulin diabetics, is characterized by insulin resistance in peripheral tissue and an insulin secretory defect in the beta cell. Gestational diabetes is an operational classification for women who develop diabetes during gestation. The other one that I didn't put up here is insulin-resistant diabetics, and that is basically patients that present with abnormal glucose tolerance test, but have a usually normal fasting blood glucose or suboptimal blood glucose. This slide here is types of diabetic, oral diabetic medication. I'm not going to go through all the trade names and classifications and routes and durations of actions and stuff, but what I want to allude on this slide is the last column, which is the side effects of oral diabetic medication. And as you can see, a lot of them, their side effect is the reason actually why we're giving the medication anyway. So hyperglycemia is one of the major side effects. When it comes to our insulins used by diabetics, we've got rapid-acting insulins, which are insulins that covers the needs for after meals have been taken. Short-acting insulins covers meals that have been taken within 30 to 60 minutes. And then you got your intermediate-acting insulins and your long-acting insulins. You do have your pre-mixed insulins that come already pre-packed, and these are some trade names of those insulins, and they're a combination of usually intermediate and short-acting insulins. Note on pediatric diabetes. Most patients that have pediatric populations are type 1 diabetics, and they have a lifetime dependence on exogenous insulin. We have seen an increase in type 2 diabetes, and I think that's usually, well, associated with the increased rates of obesity. As Simon said, our patients are presenting more obese lately than the exceptionally thin. Just points to keep in mind when you're doing sedation versus versus surgery, and this is just to keep in the back of your minds basically that major surgery is usually invasive procedures. They have overnight hospital stays, they're long procedures, and we tend to do any ASA status of these kind of patients, whether it's surgery, general anesthetic, or procedural sedation. Procedural sedation, usually not so invasive, go home shortly after the procedure. They are short procedures, and they're limited to primary care setting with ASA 1 or 2 patients. The metabolic changes from surgery in the diabetic patients, they have a stress response with catabolic hormone secretion, which reduces the insulin sensitivity. We do play with their fasting and their food intake, and we do alter their consciousness, and there is circulatory disturbances associated with anesthesia and surgery, which may alter the absorption of subcutaneous insulin. So on the back of this, I want to go through some case studies. It's just to stimulate the way you think about how you approach a diabetic patient. please feel free to add in wherever you want to. So this is a first case study, a 44-year-old presenting for extensive dental work in all 4 quadrants of the mouth, and the expected duration is 3 hours. So it's a long procedure. The history of note is he's a diabetic. He's on hypertensive, aspirin, something for cholesterol, something for his mood. He's had a previous cholecystectomy. On examination, not too obese, Malampati of 2, and his HbA1c is 8, taken a week ago. Is that of any significance? Yeah. Why would you? Okay, so I suppose not on the day of surgery, you want to know that, but an HbA1c of 8 over prolonged or many current HbA1cs that are above 8 indicate microvascular disease, yes. Okay, and so what is your plan regarding the procedure? I don't necessarily want to know what kind of drugs you'll be using, but what is your plan if you will proceed with this kind of procedure? Anyone would proceed with this? And we're talking about sedation in the primary setting here, hey? Not in theater. No one will proceed with this? The majority. Ilse? You speak well? Would you give us just your plan? And I'm talking about, would you keep...
Obviously, you will have everything to assist you. And sometimes, obviously, that patient is most probably a little bit dehydrated when they come here because they're diabetics. So I will have my little test machine and just see, if that guy is used to a blood glucose of 8, I'm not going to change it to 4 because it's academically correct. He is used to that. His body is used. If you're going to, and especially for dental work, there's not a lot of fluid movement. There's not a lot of bleeding. And the nice thing about sedation, I always tell the people, I can sedate anybody. Because what is sedation? Is sedation propofol? Is it opiates? Is it, midazolam? Maybe this patient needed a 7.5 milligram of dormicum, and that's all. So I won't say, listen, we can't continue because he's not 100%, his glucose is not controlled. So
Okay, great. Would you keep them nil pass?
usually what happens is he was on glucophage.
Yes, yeah.
So it was the previous night. Okay, I won't give him his medicine on the morning. I'll also
Thank you,
skip that. And then I will test his sugar during the procedure and make sure that, if he only take his tablets when he starts eating again. So if he removed, say, for instance, 20 teeth and he can't eat or drink or anything, then obviously you'll be a little bit more conscious.
Ilse has basically given this lecture in 2 seconds. Simon, I see Simon wants to say something there.
Okay, I agree with Ilse, but just in terms of the metformin, so it's not going to actively drop your blood glucose. So you can consider in these patients that they continue with their metformin even in the starvation period. That's the one thing. And then the ACE inhibitor, again, just depending on you may consider stopping that more than 24 hours before. So there are a couple of considerations with the meds. So look, that probably applies more to the general anesthesia perspective, but you might consider treatment break from that. But the metformin by itself, you can actually probably continue, especially in terms of isolated by itself. If you can continue with it quite safely. It's even in starvation periods, it's not going to change your glucose. Just the metformin.
Great, thanks, Simon. Okay, so the next one is this quite a simple one. It's a 5-year-old boy, insulin dependent, presenting for dental work, and work needed to be done is obviously a mystery because the dentist has not been able to examine the child properly. On examination, the child is normal, healthy 19-kilogram child, and is just on insulin. Would we go ahead with this patient outside the operating room? Yes, no? I see a lot of nodding heads. Dr. Mula, would you? What would your plan be going forward?
It comes back to any other sedation, all the necessary precautions you're going to take in this 5-year-old boy. And again, the starvation, I would accept 4 hours, even though with the diabetic, they said delayed gastric emptying, but I'm happy with the 4 hours. Make sure that his blood sugar is normal, and it'll be the normal sedation, like you would do for any other patient.
Okay, so what Dr. Muller said now is exactly what I wanted to elicit. The principles stay the same for anything that you do. Okay, and the last case study, this is for Louis, that's been trying to tell us about, a morbidly obese patient. So this is a patient presenting for a dental extraction. The dentist will tell you it's going to take 10 minutes, but I've been in that process, and it's been the longest 7 weeks of my life. So, so that's what the patient looks like. It's not really a known diabetic, but their sugar is by definition diabetic, and they got a low-grade temperature, is nil per os. Would you sedate this patient? If no, what's your alternatives? If yes, how would you go about it? Any suggestions? Yes, Louis.
What's the cause of the temperature? Abscess. Then it's got to be done if that's the cause.
Not every abscess is systemic, though. There might be something else going on. Just remember, just because you've got an abscess doesn't necessarily mean that you've got a temperature.
Simon, you mentioned it earlier, Sauvignon patch, examine your patients. It's not all in as clear as what you say, what you think. Okay, great. So points to keep in mind for diabetic patients undergoing a sedated procedure. There's a metabolic disease profile, hypertension, dyslipidemias, metabolic syndrome. They've got central obesity. They've got limited joint mobility, which occurs in 50% of patients that have had diabetes for longer than 10 years. There's a decreased extension of the C-spine, gastroparesis, peripheral neuropathies, delayed gastric emptying, and there's an increase of a lot of other disease profiles here as well. Know the medications that they take and the duration of action of all the medications that they take. An approach to sedation in the out-of-hospital setup in the diabetic patient, it's just a summary. Examine your patients. Pre-sedation assessment is always imperative in anything that you do. Intraoperative management, consider an IV line, and when I do sedate patients, and I usually put an IV line for the majority of all my patients, whether they're diabetic or not. I just feel that I'm more in control that way. Blood glucose measurements, consider glucose, insulin, potassium solutions if you're going to sedate for long procedures, and we're talking about vasolipos and those kind of things. There's different regimes for that. You can look it up, or I can give you what I use. And procedurally, just have a lower threshold for antibiotic administration in your diabetics. Avoid your NSAIDs, and commence meals and drug regimes as normal after the procedure itself. An approach to sedations in the out-of-hospital setting, just to continue on that, it's limited to ASA 1 and 2 patients, as we said numerous times before, and that's the imposing limiting factor. We have tried to attempt to schedule these patients as early as possible in the morning. Nil per os as per guidelines. Some prefer 8 hours. After listening, Reinhard, others might not give them something to eat straight away. I don't know, but I mean, we do try to have a nil per os period. What Ilse said there, stop the medication, the oral medication on the morning of surgery, and resume at regular time after surgery. After listening to Simon, that's something that you consider carrying on with him. I'm not really too perturbed if my patients have accidentally taken their medicine, because it does happen. When you get there on the day, you just monitor them more closely. And with your insulin-dependent diabetics, they say your intermediate acting insulins, you need to be taken at about a 50 to 75% of the evening dose, and your morning dose about 50% of your usual dose. Just a short note on some anesthetic agents and diabetes, and this I added this morning. So they say about etomidate, it blocks the steroidogenesis and hence the cortical synthesis, and therefore can lower your glucose in normal patients by 1 millimole, they say. Diabetics, they're not too sure the effect of etomidate there. Benzos, same thing basically. And we're talking about high doses here, hey? All right, and opioids, it can, if used in industrial doses, it can limit the catabolic hormone response and therefore abolish the hyperglycemia seen in some patients. Propofol, it's not known really what it does to the insulin secretion. We just know that diabetics have some reduced ability to clear lipids from the circulation. This might be not very significant for sedation because you don't use big doses of propofol unless you're doing long cases where you use a lot. What about the fragile ASA2 patient? And this is where our problems usually arise when it comes to diabetics. These patients they present on the day for surgery with significantly elevated blood glucose levels. It's good practice to make a decision whether you should go ahead with this patient or not, and whether it's in the best interest for this patient to get their glycemic control better. Most times you probably will go ahead if it's not too crazy elevated. And the general recommendation is that below 10 is the optimal for safety in the office setting. A common complication of diabetes in sedation is hypoglycemia, and that's from the meds that they've taken and if they've been fasting. And you need to monitor them closely. It's not easy under sedation. They do have sweating, agitation, and tachycardia. You don't know if that's from pain or if it's from your surgeon or if it's from you, but yes, just keep it in the back of your mind. And I always say rather a transient hyperglycemic state than a hypoglycemic event. In hospital, we said basically you need to do all the normal special routine examinations, and if your patient is compromised, go low, go slow. And the following slide is just a picture in the good old days why operating rooms were called operation theaters. It was a show. Thank you very much. Any questions?
Thank you, Peter. Any questions? You're lucky. No. Louis, who's next? Is it Sherwin or Mohammed? Mohammed, right. Yeah, sorry, if it was like. Ladies and gentlemen, Dr. Muller is a specialist anesthetist from Pietermaritzburg.
No, specialist family physician, not anesthetist.
Sorry, apologies for that, but he's very knowledgeable. He knows as much as an anesthetist. Mohammed did a case earlier this week that he presented to the WhatsApp group, and we've decided to quickly give him some time. He says only 10 minutes, just to play the video, and then we can have a short discussion after that. All yours.
Rena, thank you very much. Thank you very much, and good afternoon to everyone. I was told yesterday that I have to give this mini presentation, and with the caliber of speakers that we've had this from yesterday and today, it was a daunting task for me to get something ready, and to the extent that that we had in the past couple of days. I just wanted to share some of my experiences with this particular sedation that I did. Now, before I carry on and describe exactly what was done, I want you to run through with this video.
Going to 15 and 20. 20 cutting, 15 forward. Where's the instrumentation that sets for the thing?
Yeah, they sensor.
Walking stop, please. No. Next. Can you get me at the bakery?
Okay.
Okay. Mm-hmm. Huh? We're just lifting up the muscle.
So you don't have time to change.
So the markings are made. Right. Window. Key point. So this goes there. That goes there. Right. Now you have to touch me with it. Oh no, wait, don't worry. Okay, a little bit of noise, Mrs. Diana. Some irrigation, please. This goes on TV.
Nice deep breath through your nose.
Oh yes. Now how are you to do that?
You're going to feel a bit of vibration now.
Here's it coming up beautifully. Here's the cartridge. Nice, 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 nice. Looking fantastic. Everything looking beautiful. So this muscle is unfortunately very stuck. Here's it coming up beautifully. Here's the cartridge. Nice, 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 nice. Looking fantastic. Everything looking beautiful. So this muscle is unfortunately very stuck. You can relax. You can relax now. Tell me when you're ready for the substitution. Breaking up.
Yeah, the other one was better.
This is the one.
Try again.
1, 2, 3.
No. Okay. I thought that. Yeah. So, 1, 2, 3.
1, 2, 3.
No. Breaking. Let's go back to that one. This is the one you were happy with.
Yeah.
The 8.
Okay. Try again. 1, 2, 3.
1, 2, 3.
Try again.
1, 2, 3.
Much better.
Right. 1, 2, 3.
1, 2, 3.
Let's try one smaller than this. This is I was happy with that. Okay, go.
1, 2, 3.
Oh no, this is better.
Way better. 1, 2, 3.
1, 2, 3.
That's fantastic. Hey, hey, hey.
Hey, hey, hey.
It's the first time the 8 sounded stronger.
Okay, go. 1, 2, 3.
1, 2, 3.
Again.
1, 2, 3.
Hey, hey, hey.
Hey, hey, hey.
Try he,
He,
he.
he.
It's between the 7 and 8.
That's the same, huh?
Okay, try say he.
Oh, no, absolutely.
Right, done.
Absolutely.
1, 2, 3.
Oh, yes.
Oh yes, found it. That's the one. 1, 2, 3.
1, 2, 3.
That's the one. That's the one.
Okay. Yesterday, I think Reinhard said to me that you do everything. No, I don't do everything. I do just one thing, and that's sedation. But it's the surgical procedures that change. The principles remain the same. Now, in this particular patient, it was a challenge, and I always want to take on challenges. And this is just a slideshow of my private life, that what challenges I've been through. I've done 20 comrades and Kili and Mount Everest and Machu Picchu. And so I looked upon this case as a challenge. When I was asked by the ENT surgeon, I do his slates on a regular basis, that he's got a thyroplasty to do. Now, a thyroplasty is done in patients that lose their voice because of recurrent laryngeal nerve damage, either due to trauma or most commonly post-thyroidectomy. And this patient had her recurrent laryngeal nerve severed during a thyroidectomy in November last year, and she couldn't speak. So the challenge was going and doing the pre-anesthetic ward round and chatting to her, but luckily her husband was there, and we were communicating by means of writing. Now, the most important consultation is with the patient. And like, Prof said to me the other day, it's about the patient understanding what to expect. And when you take any surgical procedure on, you're going to ask yourself, what are the challenges for that? Whether it's an obese patient, diabetic, a child that's under the age of 3, you have to have a plan in place as to how you're going to deal with it. The principles remain the same. And intra-op, I termed a phrase psychosedation, because the patient knows I'm going to be there. I was holding a hand intermittently just to give her comfort and make sure that she knows I'm going to be around, and I'm chatting to her all the time, giving her the necessary reassurance. And also she knew she had the option of indicating to me if she was in any discomfort. I never use the word pain. I always ask her whether they're comfortable and whatever. So if you look at the challenges with this particular procedure, is that we needed the patient to speak to us. The ENT surgeon uses a prosthetic vocal cord made out of silastic material. And the only way he can determine whether it's going to be functional or not is to get the patient to talk. So when he asked me whether I can do it, and I said, I love challenges, I will do it for you, and we've done about 6 or 7 in the past couple of years. I've changed the drugs around because at the end of the day, I already talked about the drugs just now, but speech is the most important thing. And secondly is movement. We don't want the patient to move. The surgeon is working in tiger country, in the neck. If the patient moves unconsciously or even voluntarily, we've got an issue. And also we're dealing with a patient that's covered with drapes, so I can't see the face to keep the surgical field sterile, and the airway. How do I maintain the airway if I'm going to cover the patient's face with drapes? So I devised a technique where I use a nasopharyngeal airway, and I cut the top off of the nasopharyngeal airway. Because the nasopharyngeal airway was going to be under the drapes, I put a suture through it, and I fed the suture under the drapes with an artery forceps. So in case the airway slipped too much, I can tug it back. And also it allowed me to use my nasal prongs for the oxygen and to monitor capnography. I think in this procedure, the most important monitor is the capnogram, because it's real time and I know my patient's breathing. So these were the challenges I faced. And then these are the drugs I've used in the past. And over the years, I've decided that the drugs I'm going to use is propofol, remifentanil. Now, I used dexmedetomidine in the past, but you might want to know, why don't I use fentanyl or alfentanil? I just found that the use of remifentanil is far more predictive. I can manipulate it. even though I know people will frown upon the fact that it's a spontaneously breathing patient, how do you still use remifentanil? I use it very successfully. I use it for my eye cases. Patients are awake, they're breathing spontaneously, and I find I can increase or decrease the depths of sedation at the punch of a button. I have used dexmedetomidine, but then I had to use fentanyl with top-up doses. So at the moment, my drugs of choice is propofol, remifentanil, and ketamine. Why don't I use midazolam? Again, I'm not sure whether it's going to be predictable or not in this particular case. If I'm doing a dental case, I would use midazolam. If a patient moves around, no issue. In this particular case, I wanted the patient, for the surgeon to have conditions of a GA, but the patient needs to be awake. So, because I do not use midazolam in these patients, I use propofol quite effectively as a pre-med. And I will give them 3 to 5 moles as a bolus as the patient gets draped and the patient is prepared, being prepared for the surgery. So it gives me time for the patient to start calming down. And then I will start my propofol infusion. And I run a TCI between 1 and 1.5, depending on the depth I require. I will not start the remifentanil immediately. I will start the remifentanil knowing that the surgeon is about to make his incision. But somebody asked about local anesthetic. He only does local anesthetic, infiltrates the subcutaneous tissue for the incision. There is no other local anesthetic used, and he only used 1 amp of xylotox with adrenaline. No blocks are being used because we don't want to interfere with the other functioning recurrent laryngeal nerve. And I use ketamine intermittently. In this particular case, I only used 1 dose of 20 milligrams of ketamine, 2 moles at the time when they used the saw, because I didn't want her to move then, because it's cutting through the thyroid cartilage. And as I said to you, during the procedure, there was constant reassurance, holding the patient's hand. My choice of words, I made sure, would not instill any kind of anxiety or fear. The monitoring, vital signs, pulse rate. To me, the pulse rate and capnography was the most important, because when I seen the pulse rate going up, I knew that she was becoming either anxious or experiencing some pain, and I would increase my propofol or the remifentanil. I started off the remifentanil on 0.6 micrograms per kilo per hour, and towards the end, I dropped it down to 0.3. When it was all finished and the drapes were taken off, the patient was wide awake, and she was absolutely thrilled at the fact that she could hear herself after 6 months being able to talk again. So it's nothing fancy. It's just, I think, using the information I had at hand, using the correct drugs, and yes, we had a very successful sedation and a very happy patient. So if there are any questions with regards to this case, please feel free to ask, and yeah.
Just quickly want to ask about, I saw the capnograph, and I know that you use oxygens, and the capnograph is a side stream capnograph. And at one stage, the CO2 was 26. Now, what I personally find is that depending on the flow of the oxygen, your side stream capnography can be a little bit, the CO2 can show lower as I think what it's supposed to be. What flow rate did you give the oxygen at?
I kept it at 6.
At 6, yeah,
because
that's
she was an
quite
obese
high.
lady, she was
Yeah.
an ASA3. As you could see, she had systolic hypertension, uncontrolled hypertensive, diabetic, obese, OSA. So I just wanted to make sure that the SATs were fine. I didn't take particular attention to the CO2 levels.
No, that's,
Yeah.
the thing is that I know that you can read a lot of things in the absolute value of CO2, but in her case, I think you were more interested in the graph of the CO2
yes, absolutely.
than the absolute value.
I just needed to make sure that it was a nice, pretty graph on my monitor. Thank you. Any more questions? Yes.
I was interested when you said you cut the nasopharyngeal airway.
Yes.
I was curious as to, do you mean the tip by the
The top,
nares?
you know where you put the pin through, the flange?
Yeah.
I cut that off. So well, the result is that my nasal prongs will sit nicely, and I had a bit of micropore over the nose to keep it in position. I didn't want it to slip out,
Okay.
and it was secured to the side. And
Thank
then I
you.
had a safety mechanism with the suture, so if it did go down too much, I would just pull it out.
Very interesting. Thank you very much.
Right behind you.
Did you have any problems with itchiness with the nose, with the remifentanil?
Absolutely nothing. I find with remifentanil, I haven't as yet got a patient that complained of itchiness. Fentanyl, almost every second patient. And I find remifentanil far more, for me, I know it very well, and I am comfortable using it in spite of the patient's breathing spontaneously.
Thank you.
But no bolus doses of remifentanil. Thank you.
Mohammed, thank you very much for a very, very informative talk. Every time we have the bios on here, somebody takes it off. Louis, please. Word documents, right. I went there. Okay, there we go. Sherwin, meanwhile, where are you? No, it's fine. While Louis is, thank you, Louis, is arranging everything for us, Dr. Sherman Prim is a registrar at Tygerberg in anesthesiology. He's completed undergraduate training University of Witwatersrand and a Bachelor in Science with honors in Genetics and Development Biology, as well as a Bachelor in Medicine and Surgery. When he starts doing this, don't worry, he's got a passion for music and he's a percussionist. He will talk to us on the use of remifentanil in labor as opposed to the other regular modes of analgesia. Mark, kom net toe daarbo, né? I'll say, right, there you go.
Okay, so I'm going to have to compensate a little bit for height. Some of the speakers are a little bit taller than I am. I'd like to start off by saying thank you very much. Thank you very much for the opportunity to actually present this topic. It's not very often that a registrar gets to present a topic at a congress, so I would like to say thank you very, very much. Especially when you're standing next to speakers that are probably experts in their field. I really do appreciate this opportunity, and I'm humbled by it. As Reynard said, I am a registrar in anesthetics at the moment, and I'm certainly no expert. But after having given this talk at one of our academic presentations, it certainly gave me a little bit more of an appreciation for pain management in labor. And so the topic that I'd like to present is, I will focus on remifentanil, but it's rather the approach to label analgesia, non-regional, and I'm going to limit this specifically to pain in labor, as opposed to perioperative pain management and post-operative pain management related to cesarean section or anything else. So to start off, I am receiving an honorarium, and I don't have any affiliation to any pharmaceutical company, and certainly no financial interest in any pharmaceutical company as well. I do, however, have some recent companion experience in birthing a child. In fact, very shortly after this, I was told I actually took maternity leave from the hospital. So it's just because it overlapped with my exams. Another point that you should never do. So to start off with, I think just as an overview, so I'd like to would like to certainly go into an introduction. I'd like to focus on something a little bit important, and I find that it is very important that we focus on this, and that's the physiology of pain in labor. And it's because we often neglect it. And the adverse effects of labor pain. Certainly the management of labor, including non-pharmacological, pharmacological, and I'm really going to touch a little bit on remifentanil PCA in this as well. So when we look at this, so childbirth is basically a normal event in most women's life. And it certainly is not limited to women. I think we can actually include the couple, dad and mom. It certainly makes me feel a little bit inclusive in this situation. But by far, it is considered one of the most painful experiences that a woman will go through in her lifetime. Studies have actually found that with regard to pain management in labor, very often the management of the pain is not the overriding factor when it comes to a satisfactory birthing experience. And very often, the attitudes and behaviors of a caregiver, as well as preparation for that labor experience, as well as a sense of control of her labor is actually quite important. And it actually by far overrides the management of pain or a negative birthing experience in terms of pain management during that time. So, having said that, we are often very bad at managing pain in labor. In fact, we're notoriously bad. And for something that we manage every single day, something does need to change. So I'd like to touch a little bit on the physiology of it. So pain in labor can really be broken up into certain stages. So obviously during the first stage, the second stage, and you have a little bit of transition between there. But during the first stage, that pain is really related to that cervical dilatation and the progressive effacement of the cervix as well. And those are actually transmitted by unmyelinated C fibers to your T1 and L1 segments as well. As you progress a little bit further on through that transition, 7 to 10 centimeters, you get sort of a mixed component. And during this particular portion, you get a mixture of somatic as well as your visceral pain as well. And so it's quite important, especially going through the second stage where you get more ischemic type of pain, and that's related to the vaginal canal being progressively distended as well, and you get progressive distension of those mechanical receptors. So it's very important that we actually understand the phases of pain that these women go through, and particularly where this pain localizes to, because very often during that first stage, it will localize to the lumbosacral area, particularly sacrum, as well as thighs, anterior abdomen, and the lower back. So I think that's just basically a little bit of a thing over there as well. So adverse effects of pain, number one, what is the typical, how many people work in an environment where they're in a labor ward? What's the typical thing you hear when you open the door? Okay. So screaming. So can anybody tell me, and certainly I think maybe perhaps one of the ladies in the room, what are the physiological manifestations of pain that we typically experience, things that we can observe and see? I'm maybe even gonna, Nicole. Okay, so okay, so that's great. So essentially, we get sympathetic activation. We get a woman who's hyperventilating, who becomes hypocarbic. That whole cycle actually increases catecholamine release. The hyperventilation causes hypocarbia, which essentially causes a left shift in your oxygen hemoglobin dissociation curve as well. All of these factors contribute to progressive increases in your systemic vascular resistance, as well as a reduction in placental perfusion. That left shift also means that you've got less offloading of your oxygen to your fetus. So not only is pain bad for mom and those watching, but pain is also bad for your fetus and baby. And essentially the two main consequences of it is a fetal hypoxia as well as fetal acidosis. And so the point of good analgesia in labor is to actually prevent those adverse effects as well. So that's just a little bit of a thingy as well. I think it's actually, I'm just going to try and see if I can change things down on here as well. Okay, so management of labor pain. I did have the opportunity of having my hand held. I can tell you, don't offer your hand ever again. Though it is an inclusive experience. I will say that in terms of managing pain, there is a non-pharmacological aspect to it. There's a pharmacological aspect to it that we need to appreciate as well. And there's obviously the regional. I'm not really going to focus on the regional, but what seems to work in terms of non-pharmacological approaches? We've all often seen these images on TV, I think particularly when it comes to American TV. These moms not in a hospital environment, birthing at home, immersed in water, and you're like, okay. But actually there's quite good evidence to support that immersion in water actually has good benefits in terms of labor analgesia. And so not only does it improve a little bit of the mobility because of the buoyancy in the water, but it actually causes a little bit of vasodilatation as well. Particularly so if that immersion is up to shoulder level as well. I think the reason it's not taken off very nicely is because there are, I think in our setting, concerns regarding obviously safety, which is an important concern, especially when you don't have one-to-one nursing, and those aspects can become a little bit difficult to manage in our setting. The other thing that has shown to be a little bit more of benefit as well is the use of, so it's depends on which studies you read, but TENS has some benefit, so transelectrical nerve stimulation, although a lot of these studies are actually underpowered, and in terms of the outcomes that they've measured, there's a lot of heterogeneity. So in terms of including them in any sort of meta-analysis that can actually change our practice, it does make it actually quite difficult to do. Massage, the simplest thing that you can do. Have a caregiver around, partners around, and massage has actually been proven to actually improve your visual analog pain scale scores as well. So those are things that we can certainly implement, and it's certainly things that are easily implementable as well. Some evidence has shown that the use of a birthing ball, which I've actually found quite common in some of our units, especially in private, has actually found to reduce the need for epidural as well as assisted vaginal delivery. In fact, probably by sometimes up to half, depending on which studies you do read. The benefit is that by adopting a upright position, it also increases a bit of perfusion as well, but also reduces the time that you spend in first stage and second stage labor. So it actually reduces your time that you're in labor as well as the need for instrumental delivery. caution with it is that because of the engorgement, you do get more blood loss with it, depending on which study you read again. What might work? Zen experience. So immersion does definitely have some benefits to it, and there's certainly good evidence to show that it does have benefit to it. Acupuncture, not really. I don't think the verdict is really out on it, as well as TENS. So I think we do really need much better quality studies regarding that. Okay, so regarding, and this is I think where everyone is kind of a little bit more interested in pharmacological management. So particularly with regard to the use of opioids, we've also got non-opioids and then our adjuncts. So I think to focus on it first, I think if we look at our opioids, we'll probably look at which is the queen of the poppy. But non-opioids, there is a bit of a concern regarding premature closure of the ductus arteriosus. And I think that's the reason why it's actually avoided in most maternity units or labor units as well. Certainly, some studies have found that even with a single dose, there have been reports of closure of or premature closure of the ductus arteriosus. It is particularly prevalent when it's given in sort of more chronic patients, and there's chronic use of it throughout pregnancy. With regard to opioids, and I'll actually breeze through this because I know my time is a bit limited. But what actually works? So I know in most of our units, pethidine is probably the most prescribed drug that you will find in a labor unit. And that's coming from a lady in the room. Mom, I can also personally tell you that it does not work. Yet it is prescribed like Smarties. A lot of the effect of pethidine is actually not related to its analgesic benefit, but patients get a sense of euphoria, and it's actually related to that sedative effect and that euphoric experience that the patient feels when they've been given pethidine. One word of caution. So I'm maybe going to ask this to the floor. What is the time required, or what sort of time would you give your pethidine in a woman in labor, related to the time of delivery? Okay. Okay, so the answer was five hours, and it's one of the drugs that midwives are certainly allowed to prescribe and use. It is actually not recommended to give it within 3 hours, and certainly if you're going to give it, you can give it within an hour of delivery, but who can predict that? Certainly, with its sedative effect, it's actually been proven that most women require, or there is an association with instrumental delivery with the use of pethidine. And also, it has an effect on the ability of a woman to actually push adequately during that time of delivery as well. So not only does it prolong and also causes a lot of instrumental delivery, but you've also got quite a lot of conversion to epidural with pethidine particularly. So current SASA acute pain guidelines don't actually recommend pethidine. In fact, the use of morphine is actually advocated. And that's particularly within 4 hours. Or within the hour, and that's to allow for less effects on baby. Pethidine does get metabolized to norpethidine, and so there will be rather inefficacy of your naloxone, particularly with those with pethidine, especially in the neonate. The other thing to consider is that if you've got a patient who is an imminent eclampic or has had eclampsia or seizures, pethidine is neuroexcitatory as well, and it has neurotoxic effects, and you can actually precipitate seizures in those particular patients. When it comes to breastfeeding, delayed breastfeeding, delayed latching, and sedation in your neonates as well. And I think this is probably where the use of remifentanil and some short-acting opioids actually comes in as well. So remifentanil use in labor analgesia is relatively new. I don't think too many people have actually used it quite a lot, and it certainly has needed a little bit more investigation until we've actually changed anything in terms of practice. But the reason why it is favored is because it's ultra short acting. It's got non-organ dependent metabolism, and it's actually broken down by your plasma esterases as well. And it is rapid acting as well. So you've actually got the benefit of something that acts rapidly. It's not going to stay in the system for very long. And your patient can actually control it very nicely if you've actually used a PCA with it. Secondly, you don't have accumulation and the effect on the neonate or the newborn as you would do with pethidine and, say, for example, morphine. So a remifentanil PCA is something that is a little bit of a new concept. Not too new, because I think it has been around for quite a while. Just I think our uptake has been actually quite slow on it. So indications for it actually include maternal request, any coagulopathy, ongoing anticoagulant use, declined epidural, or in cases where there might be a difficult epidural or anything, so patients who've had spinal surgery or anything, this would be the kind of thing that you would actually consider for labor analgesia. So where does remifentanil fit into in the grand scheme of things? So basically, in terms of its efficacy, I think epidural is still considered the gold standard of analgesia in labor. And that's because of beneficial effects to mom, as well as less effects on the fetus as well. And it's non-opioid. So remifentanil, the largest study to date at the moment, is actually from the Respite trial. And based on data that has been reported on the remifentanil PCA or RemiPCA European network, there's a total of 5,740 cases to date that I think have been captured on there. But the study itself and the trial itself enrolled about 401 participants. And what they actually found was that remifentanil was beneficial and superior in terms of its analgesic benefit compared to pethidine. There was actually less, in fact, almost half of progression or conversion to epidural as well. Similar rates of sedation when comparing remifentanil to IM or intramuscular pethidine as well. The only downside to it is that I think particularly when you are looking at instituting the adoption of a remifentanil PCA protocol in your center, there are specifics that have come out from the RemiPCA SAFE network, and that is basically they've got simple principles. So keep it simple and keep it safe. Number one, simple. So standardized regimens with no background infusion, low dose, and so basically no background infusion as well with it. And the current recommendation is that you basically make up a bolus dose of 20 mics per mol, that there's no background infusion, no other opioid given, so you can't give it in a patient who has had pethidine at least within 5 hours. So after 5 hours, it would be okay to actually use the remifentanil PCA. And you can actually use it with Entonox as well. So there is some benefit with Entonox and remifentanil PCA. So keep it safe. Use a standardized regimen. You do need to have some level of quality control as well. What has been advocated with remifentanil PCA is that there needs to be a 1-to-1 nursing ratio. There needs to be continuous SATs monitoring as well. And just regarding the use of SATs monitoring and capnography is essentially the gold standard. And it certainly allows us to, kind of pick up a patient who has become depressed in terms of respiratory depression, and the use of, I think, a SATs monitor and standardized use of just oxygen for every patient or supplemental oxygen certainly does mask the respiratory depression as well that you possibly are going to miss with it. So the other advice that has been given, or guideline part of it, is that just standardized supplemental O2 is not actually advocated unless the patient has SATs of less than 94. Conclusions-wise, I know it is it's a very big topic. There are notes that I've actually attached to it. It's a lot of notes, so if you are going to read it, please do have a copy of it with you and a good cup of coffee with it as well. So regarding conclusions, remifentanil PCA is actually advocated in patients where you might not have the option of doing an epidural. Patients where epidural might be contraindicated, and it's actually been proven to be more effective than pethidine. So if one thing I can probably try to convince you of is possibly using remifentanil instead of pethidine and a PCA, or pethidine, there are much better options, even if it's not remifentanil. Morphine particularly is much better as an opioid agent. And I do see that I am being approached right now, so I have hit my time limit. That tends to happen. But I just want to say lastly, thank you very much. There are a list of references that I have included with the info and the notes that I've given as well. And I just want to say thank you very much again. Thank you very much for bearing with me.
Thank you, Sherwin. Any questions, Mohammed?
Two questions I have. Number one, the incidence of respiratory depression. That's the biggest thing. The use of remifentanil. And I think that's the reason why a lot of doctors shy away from it, especially in the spontaneously breathing patient. The second thing is that there were incidences with PCAs, and now with a PCA with an opioid like remifentanil, doesn't it mean that patient needs to be in ICU?
So I think to answer that, when used in a dosage that is low, so I think commonly, I think we can all appreciate the saying, go low, go slow. Use a low dose. Most of the sedation is actually experienced in cases where there are a dosage of in excess of 40 micrograms per mol, certainly more than 30 micrograms per mol. In terms of its sedative effect, in the studies, they haven't actually found that it's, well, in the most recent one, yes, it is more respiratory depressant than pethidine, but in the RESPIRE trial, they actually found similar rates of sedation between remifentanil and pethidine as well. Regarding an ICU environment, I think for the purposes of practicality, it's something that we can't offer for every laboring patient. I think particularly with the rates of of births that we actually experience, particularly in our public sector, even more so in private. I don't think we can actually admit every patient to an ICU. In fact, one of the studies actually even showed that in the US, some of the data that was coming out of there, most of the centers that were using REMI PCAs didn't have one-to-one nursing ratios as well. And so I think that there also needs to be a change in that, because it is slightly unrealistic. There have been adverse events reported, and that has been related to respiratory arrest and cardiorespiratory, essentially cardiac arrest as well. But it should be said that in those patients, particularly, the rule of no other opioid was not actually followed. In fact, some of those patients had oxy, there was codeine involved, lots of other opioids with additive respiratory depressant effects that actually contributed to that. So also if you neglect the no background infusion rule as well, you're certainly going to have a higher incidence of respiratory depression with those patients. Practical issue. So in our setting at Tigerberg at the moment, we've actually got, we've raised that issue. Our lockout times on our PCAs are currently 5 minutes. And it is longer than actually recommended and required. So the lockout time that's actually recommended by the REMI PCA Safe Network is actually 2 to 3 minutes. And that's also because your context-sensitive half-time of remifentanil is between 2.5 to 3 minutes. So you want to try and optimize the amount of time that that patient spends in the therapeutic range for pain relief, because when you've got a PCA that locks out every 5 minutes, your patient actually spends more time swinging between no analgesia, between therapeutic range, and then no analgesia again. And one doesn't really want to compensate for that by giving a bigger dose, because then you get more respiratory depressant effects as well. So no, definitely not.
Sherwin, thank you so much. That was lovely. I just wanted to just say, for the questions that were asked also, and just to do with your topic, Dr. Philip Anderson in the Kimberley Hospital Complex actually does a large amount of practically applied remifentanil infusions off-site with nursing staff managing it based on a protocol that he's developed over time, and that specifically needs an electronic pump. It needs a pump where you can program everything, but it's worthwhile maybe chatting to him as sedation practitioners who work with labor patients about this option, because he is so happy to share his knowledge. He shared it with us at Tigerberg, which was fantastic, because for me that was something new that I'd not seen ever, and it was really, really a brilliant approach and a brilliant way to manage it, where you're not staring at the patient, looking at the capnograph, wondering what will happen if she presses the next dose of remifentanil. And he's had major successes with his patients in that particular part of the world.
Hello, thank you. My first question was actually to ask whether you do this in your unit, but you've answered it already. And then I want to know who educates the patients on using this remifentanil PCA, and how do you educate them?
So a lot of information from the remifentanil PCA Safe Network is that they've made the anesthetist actually responsible for that. So particularly making up the PCA in the PCA, and then educating the patient as well. They've focused on that from an anesthetist point of view, firstly, mainly because I think it was part of a trial that they were trying to see exactly what to play around with, what the outcomes were, and I think a lot of the information on the database that's come out has actually contributed to protocols where they've implemented training programs, particularly for midwives, that are going to be taking care of these patients as well, and nursing staff as well. You do need to certainly have a one-to-one ratio with it. And it's very important that whoever administers or is taking care of that patient is able to understand exactly what remifentanil is, what are the what are the adverse effects of it, and be able to monitor that patient adequately. So I think in terms of education, at the moment, it is still anaesthetist driven, and I think there will certainly be, I think, in time to come, as it gets used more often, more protocols related to educating nursing staff and midwives, particularly with it.
I specifically want to know, what do you tell the mom when to press the button for the administration of the bolus of the remifene?
So I think this is one of the practical issues with it, related to its context-sensitive half-time as well. One of the things that has come out with it is that by the time a patient's actually given a dose, the analgesic effect actually is only probably going to kick in with the next contraction. And so as a patient progresses in her labor, she'll certainly learn to control or get more of a sense of her labor and control of her labor as well, and know when to anticipate a contraction. And so by doing that, giving a bolus that's self-administered essentially will I'm not so sure. So I shouldn't press it with a contraction, no. Definitely. Thank you.
Last question.
Sherwin, thank you for the talk. I think this is a very interesting and novel area for sedationists to start getting involved as well, particularly if infusions are proving to be useful. Just the first question is yes or no, so it's quick, and then the second one, there's more detail. Firstly, the use of a PCA pump with any analgesia in the labor ward, have they found that that actually provides a positive placebo effect for the laboring woman in terms of being able to control their own pain? Has any research looked into that?
So there have been studies that have been done, particularly with PCA. There is an association between the control of analgesia, and particularly where it comes to the patient's sense of control of their labor, and management of their labor pain as well, where the patient is involved in management of their labor and is more included in the management, where they feel more self-control of it. Those patients actually have much better birth satisfaction scores than patients who haven't had a PCA. Certainly also because it's IV administered, your boluses that you're actually giving intermittently, you have much less time that is spent out of therapeutic range, and you actually try to optimize it more within your therapeutic range. So those patients actually have better visual analog pain scores as well. So I think it overall does contribute to better birth satisfaction scores, and certainly better pain scores with the use of a PCA. I wouldn't be able to quote you on a direct study, but I can probably direct you to one of the Cochrane reviews, I think was in 2013, and then they did a follow-up to that in 2017. It was more of an overview of systematic reviews that they did, and one of the areas that they did touch on was also the use of PCA as well.
Thanks, Sharon. It was a yes or no question.
Sorry.
I'm teasing.
My bad. Sorry.
I'm teasing. Yeah, he's got an oral exam here. He's intimidated by a consultant. Sharon, then just, I always get nervous when people proclaim a fixed dose for any drug. I think as sedationists and anesthetists, we all get a little bit anxious. The 20 mics per ml, is there a footnote anywhere in the guidelines that says this dose should be adjusted in the following situations? For example, you do get very small pregnant women. And secondly, what about the laboring woman with obstructive sleep apnea? Because that's quite common now. And we know that they are sensitive to opioids. So is there a footnote anywhere, or is that still uncharted territory?
So I think from a lot of the information that was on the REMI PCA Safe network, or initially there was a guideline which actually included, or protocol which included adjustment according to dose. So if a patient was under 60 kilograms, they'd essentially use 20 mics per kilo. Above 60 kilograms and between 60 and 90, it would essentially be between 30 to 40, and then 50 once you've actually approached above 90 kilograms. They've recommended not using a weight-based protocol at the moment. And I think the reason for that is, while you might have a variation in weight, certainly just by actually having more frequent boluses administered, a patient's actually able to spend a little bit more time within a therapeutic range. I think particularly once that patient gets a sense of how many times to press to actually get more of a analgesic effect during the next contraction as well. So I think that's one thing that has come out from the data that they've published as well, is don't use a weight-based formula, and we try to stay away from it. It's also convenient because it makes it simple for other users that are going to be using it, and certainly for those monitoring it as well. Regarding patients with OSA, sure. Working at Tigerberg, we I think in the periphery, the biggest thing is BMI above 40, refer Tigerberg. So that's a little bit of a joke that we have. But we do have a lot of patients that are above a BMI of 40 within our public setting. And certainly OSA is a concern for us. So there is current recommendation that you avoid remifentanil PCAs in patients with high OSA risk, and rather in those patients, if you can use an epidural, you would rather than use an epidural unless, let me not dig a hole for myself.
Sherwin, thank you very much. We'll have to invite you again, and the girls love talking to you. Thank you very much. It's lovely. Yeah, thank you. It's lovely to have young people come on board. Thank you very much for that. Ladies and gentlemen, our next speaker is Louis Smith, the man himself. Louis is a diplomat anesthesiologist in private practice. He's handled over 12,000 sedations over the last 20 years. He's the owner of the Helderberg Pain Clinic and an interventional pain practitioner. He's been a member of the exco of the World Institute of Pain, and is currently the deputy chairman of SOSPOSA. Louis also holds an international qualification in interventional pain management, and we're honored to have you.
Thank you. I'm just going to change my hat this morning. I started off with interventional pain, with doing sedations for this stuff. And the first time that I was asked to come and do a procedure, I had no cooking clue of what I'm going to do. And so it developed over a period of, say, 3 months that I realized I would rather do the procedure than do the sedations. So let's see how we can go. What excites me about this is when we started sedation way back in 2002, opioids wasn't allowed, children under 6 wasn't allowed to be done, and remifentanil surely wasn't one of those drugs that was allowed. I remember in 2008 I did a off-label trial trying to fool my surgeons doing colonoscopies with 80 cases that we did of remifentanil, and it was a double-blind study or a protocol that we used, and the surgeon could immediately tell me when I was using remifentanil and when I was using any of my other cocktails. I think it's a marvelous drug in the right hands. And it excites me to think that we might be able to use that drug in sedation one day. If we know how to use it, get the protocols right, I think it's amazing. When I started this level of sedations, I think we can even change the topic, because this is very, I would like to make it practical. The basics stays the same. And irrespective of what you do, this is just for a very specific intervention. And we've got very specific needs for interventional pain. By the way, who's doing sedations for interventional pain procedures, rhizotomies, neurostimulators, and so forth? Right, so there's a few of you knowing it. So I'm not going to go into too much detail. But the challenges that we have is mostly that we deal with the older populations with comorbidities, who's got multi-pharmacology, the obese patients, painful body parts and painful movement. So it's not always the easiest patients to handle. By the way, I just want to make this comment. I think a lot of physicians have a malperception of pain. I'm dealing a lot with chronic pain versus acute pain, and there's a major difference. Dr. Muller had a slide on psychosedation. I love it. How many of you have fooled a surgeon? I need more. You put the syringe in, you do nothing, you pull it out, and man, the patient is fine, according to the surgeon. So there's a lot of psychology in this as well. And a lot of it starts with how we prepare our patients. What's their perceptions, what's their needs, what's their wants. One of the biggest challenges here is that the patients are done in a prone position. Like Simon said this morning, it might be a blessing in disguise, but it's also those patients the airway is not that easily controllable if you run into trouble. And the main thing here that I want to highlight is airway management. This is probably our number one challenge as far as this is concerned. Now, what I've learned this weekend, I always thought oxygen is my friend. Now I find out that oxygen might not be good in sedation. How do you know when your patient is on the way to crash if you've got oxygen prongs on? Is it a routine thing, or should we wait till the patient crashes before we put the oxygen on? Right, just more challenges. The level of sedation is critically important in interventional pain for a few specific reasons. The success of this procedure depends on your patient's cooperation and how accurate you are as an interventional pain physician. Right. Your patient must be awake enough so it can respond to nerve stimulation. So number one, your patient can't be on a GA, they can't be having neuromuscular relaxation on board. Right. And they've got to be able to talk. The other thing is to be accurate in these things, you want minimal or no movement. Remember, whenever we place these needles, you're quite close to big nerves and spinal canal. And the other thing is any slight movement under an X-ray or a C-arm changes your position. So if you put the needle in, the patient change and didn't come back to your exact same position, your needle placement might not be accurate, or you will have to reposition the needles. The procedures are not supposed to be done under general anesthetics, and this is one of the guidelines that I'm fighting for, that unfortunately a lot of the surgeons does these procedures under GA. There's no ways I can stand up and fight for you in a court of law. Number one is, how do you stimulate the patient? Number two, how do you measure the patient's response? That's all I need to ask. And if you can't answer that, I can't help you. Right. And then radiation risk. The more a patient moves, the more I need to replace my needles, the more I increase the risk of radiation in theatre. Now, you probably will know that everybody in a theatre, the responsibility of radiation becomes the surgeon's problem. And your anaesthetist needs to be aware of it. Everybody needs to be wearing protective gear. And also, if you want to be safe, don't come closer to 3 meters of the radiation cause. As far as the sedation is concerned, one of the important things is, remember, is our breathing. Now, you've seen the big guys with the big paunches and like the pregnant fairies. How do they breathe if they lie on their stomachs? So what you need to do is to have a good good position of protecting your pressure points. Normally put a big pillow or two underneath the chest and underneath the hips so that the paunch or the stomach have breathing space. It means that your patient might lie this high from the table, but at least they can breathe. The moment they start laying on their stomach, you will get a desat patient or breathing problems. The other thing is, from a technical perspective, if you turn the patient on their side, it's not always that easy for the surgeon to place their needle. So whose problem is it? Yours, as the sedationist. Right. The other thing is, there's different techniques on how you place the head. I've got this little pillow or silicone thing that we can put the chin in and put the forehead on, and the patient, you've got nice breathing or nice space where you can actually still manipulate the airways. And just basically how the patient is positioned. And I've specifically placed this photo here. We work a lot in the neck. A big fat patient, there's no ways that you can do a lateral on a patient and place these needles correctly. On the other hand, if you see a surgeon placing a needle from lateral in the neck, you fire him. Okay, because that's the biggest place where you can run into complications, where you can nick your vertebral artery and you don't even know it. If you come from behind or posterior, the chances of hitting the vertebral artery are a lot less, and your needle will most probably just go onto bone. So this is one of the things that you as an anesthetist or sedationist should also be part of the protocol. What's safe for my patient? Right. How do you know if a patient, or how are you going to handle it if a patient gets a needle into his vertebral artery? Those patients normally don't react immediately. There might be an incident, but mostly not. It's only post-op that you find these patients starting to present with neurological fallout. Is it your cause, or is it because of what the surgeon did? And if they wake up with a stroke, okay. And the worst complication that I have had was, fortunately for me, just a patient who had a hematoma, but needed surgery afterwards to go and drain the hematoma. So we get caught out. We unfortunately don't always do the proper pre-op evaluation, and some peoples don't acknowledge being on blood thinners. So to them, aspirin is just routine. Right. Just to give you an idea of where we place these needles, and again, if we work with catheters, I don't know if you can see it, but we place catheters from normally, if you go below, this is below a lumbar fusion, and it's sometimes difficult to place these catheters because where surgeons are, there was always trauma, right? And they pack bone everywhere, and it's not always easy to manipulate these catheters. But because of that, I want a patient that is awake, that if I do cause trauma, I want to know it immediately, or where do I stop and where do I push through? The other thing is, you can see the needle placement of identifying a dorsal root ganglion and nerves. If this patient moves and that needle slips right into the spinal canal, you've got problems. So here's the trick for us as sedationists. How do I keep my patient still and awake, but not to the point where it's uncomfortable for them? And this was just, the last one was just a little discogram. So you push a needle past the spinal cord. If that patient moves, it's like those of you who do kyphoplasties, the same type of story. You've got very, very small margin of error. And if your patient is moving, it becomes very difficult for you as an interventional pain physician to place these needles. Right. I'm going to stop here because I think Dr. Mula has given us a lot of info of the different protocols. Maybe just a comment, know your surgeon, pick your patient, pick your surgeon, plan your procedures beforehand, what's available, what's possible, and what are you comfortable with. A lot of the surgeons are quite fast. If you do a diagnostic block, it can take you 5 minutes, so therefore you don't need infusion. If there's more of the longer procedures, for instance, placing neurostimulators and so on, I like a remifentanil infusion because it's something that you can start and switch off. While you're doing the surgical incisions, placing or pushing stuff, is a very good drug. And if you don't need it, you stop it and the patient is awake and you can get your responses. So there's horses for courses. Plan your procedure. And the question that I always pose to myself, what would be the best outcome for my patient? All right. I'm going to stop there. Thank you. And then we can finish earlier. Hope there's no questions, then we can go home sooner.
Would you be so lucky?
Can I just quickly add, I just want to do a quick thing. Yesterday, Graham spoke about the 4 quadrants. What do you need? A patient that's awake or a patient that is moving less, and adjust your protocol accordingly. That's one of the tricks that I want. Ooh, there's one quickly. Just remember, the other thing is, especially when you're dealing with obese patients, don't forget that nasopharyngeal tube. I love it. And I always have one in my bag because you never know when you get to a surgery and you get these people who easily obstruct. A nasopharyngeal tube, man, it works like a charm. You don't get airway obstructions with it. All right. So, and then, remember the psychosedation story is vitally important. You can talk a lot of people through a procedure without doing any drugs. And I think that's something that we can do a lecture on as well. In pain, we've got 2 topics these days which are very crucial: neuroplasticity, which I think is vitally important. Who of you know anything about neuroplasticity? Okay, very important science, neuroscience. And then the other thing is cognitive behavioral therapy or mindfulness. And believe me, you can think yourself sick or you can think yourself healthy. You can think yourself full of pain, and you can think yourself without pain. Thank you.
Thank you, Louis. Ladies and gentlemen, our next speaker is Dr. Vickers Nienaber. You all know Vickers. He's a member of the our EXCO, and Vickers will speak on convulsions under sedation. Vickers, by donkey.
Thank you again, and I think you all know me. We are running a slight little bit behind in time, and Prof asked me to do the talk, or not the talk, to ask you to give me the talk. So it's a bit of a reversal here. But before I start with my talk, I just want to know if any one of you know anything about permeability enhancers in the use of drugs. I'm talking about stuff like DMSO and hyaluronidase. Anyone used it, because there's quite a bit of research going on since about 2007 in the Asian countries on these permeability enhancers, and we might just be able to deliver drugs intranasal or oral in incredibly small doses, because with DMSO you can have the absorption tripled or 5-fold better. You get virtual intravenous effects from oral. I'm just leaving it there. I think we might be able to, in 4 or 5 years from now, to have a nice talk about that. But let's look at psychosedation. That's what you do for the patient. Confusional hypnotism is what you do to the surgeon. You are going to suck properly. Convulsions. Convulsions under sedation happens very, very seldom. In fact, one of my first questions I'm going to ask the audience is, how many of you have had a patient pre-sedation, during sedation, or post-sedation with a convulsion? 1, 2, 3, 4. The incidence there, 3.4 per 10,000. But look at that next statement. EEG tracings confirmed 25 times higher suppressed incidence, 7 per thousand of tracing suggestive of epileptogenic foci suppressed by the anesthetic drugs. So this actually happens to us all the time, we just don't know it. So keep it in mind. That brings me to the next question. We are seeing patients with epilepsy in our sedation practices and in anesthesia, quite a few, from trauma, from birth injuries, etc. And we don't see all that many of them ever having an epileptic fit. So then the question is, would you do an out-of-hospital sedation for a known epilepsy patient? Anybody in the audience? You say yes. You would do that. Ha. Okay. So before we get to that, but you are quite correct. How many of you have seen, and one of my dentists describes that as the walkies. You start doing a sedation and the patient starts walking. Or the walkies, the talkies. The sudden, non-temperature related shivers. We see that. Good. Then a separate discussion, but related, restless legs. We see that quite a lot. And what would be the reason? Why do we see these things? What about propofol? What about midazolam? What about the drugs that we use? Is it the panic or the anxiety that's causing it? Or might it be the drugs? How many of the drugs that we use increases the chances for convulsions or increases or changes the threshold? Virtually all of them. That's the answer. So let's get to the next one. If we look at convulsions, we've got a differential diagnosis that would go out the front door. There's a huge number, but I think the practical stuff, we have epilepsy, then the non-epileptic attacks, for instance, the panic attacks. Never forget serotonin syndrome that Prof had talked about. Then cold shivers and shudders. And that's why I made the difference with the temperature. Paroxysmal sleep, shivers, shakes, neurological movement attacks. Then this walkies thing. Smokers on nicotine withdrawal. And that's something that I would like to ask the audience again. What do you do with a heavy smoker that you've got to do a sedation for 3 hours? What do you do with him? Because for sure he's going to start moving. Ilse? How many of you carry nicotine patches in your bags? It's practical. Often within the first hour. You have a patient that's perfectly sedated, they're working here lovely, and then suddenly he starts moving and he's fighting. And you give him more sedative drugs and he's fighting and he's getting more difficult by the minute. Heavy smoker. And you give him a nicotine patch and the next moment he just goes like, oh, I could go outside and have a smoke. He just totally relaxes. You don't have to give more. It's a simple, practical little thing. Just remember the heavy smokers. Okay. Malignant hypothermia, don't ever forget about that. And then benign sleep myoclonus, which is also a lot more common than what we think. What do we do with patients on long-term oral sedatives, for instance, for panic attacks and anxiety? So you've got these patients that come in your pre-med, you find out that they are using benzos, pretty high doses. What do? Do you stop it before they nilperos? Do you ask them to take their regular drugs? Now you're doing a long sedation. They have been nilperos, they're stressed out, and they probably need actually more benzos than what they commonly use, and you've taken it away. They are going to give you problems. So just think about that. It might be very good to make sure that they get their drugs. Because they've got a convulsive threshold change. They could get their convulsions. Okay, so if you've got a patient with a known, and now we're getting back to you, a full history of the causes, understand what causes it. Some patients might go into a convulsion purely because you've got a flickering light above them. So you need to talk to them. What drugs are they using? How many attacks have they had in the past year? How many attacks have they had in the last month? How many attacks have they had in the last few days? Okay, so I'm trying to get this talk a little bit shorter, so forgive me if we go a bit fast. So prevention. Continue anticonvulsions in the perioperative period. Avoid common drugs lowering the convulsive threshold. Now, we just heard about pethidine, and you are so correct, especially in renal patients, because the pethidine is a big problem with convulsions if they cannot get rid of it. Most anti-cancer patients, so during chemo, then a lot of the antibiotics changes your threshold. In this case, imipenem is very, very well known to be a problem. But I use Kevzol 2 grams in anesthetics, and I didn't know that it increased your seizure potential by 15%. How many of you knew about that? Quinolones, problem, anti-diabetic agents, mostly because of the hypoglycemia, antipsychotics, aminophylline, not used so much anymore, but remember to give it in a lower dose, and remember to give it very slowly. Then a lot of the kids these days are on sympathomimetics, Ritalin especially, phentermine for the ladies that wants to lose weight. We had a short discussion on entomidate, so I'm not going to repeat that. But then tramadol. I use a lot of tramadol in my practice. So tramadol can be a cause of convulsions, but it could also be a treatment. Avoid hypertensive responses, avoid hypoxia, hypercarbia. There's a question whether your known epileptic patients should have supplementation of oxygen, especially if you're using opiates. There's a whole discussion about that. There's quite a bit of research. I think the answer is dependent on what you are using during your sedation. Are you using anything that's going to lower the oxygen, and in that case the supplementation makes sense. Then there was, for quite a while, there was a story that you should avoid ketamine. Well, that's BS to the nth power. It's less epileptogenic than normal sleep. Perioperative correction of electrolyte imbalances makes sense, but then most of our cases are ASA 1 and 2, but for the cases that we do in hospital for the ASA 3s and worse, obviously that makes sense. And then local anesthetic agents, we should be very careful. I think before I get there, what would be the immediate reaction if you have a convulsive episode during, before, or after a procedure? You know, if you don't think about it, when it happens, you have to think about it, and then you've got a patient that's shaking and carrying on there and breaking his legs and dislocating his shoulder. If you haven't thought about it before, then it becomes a problem when you've got to handle it. So that's why I want the answer. What what would go into your head first? I'm doing a sedation, and the next moment this patient has got an epileptic fit. What are you going to do? Maintain the airway. Stop the medicine. Well, I'll tell you what I'll do. They fit, and there's some people to help them and hold them and carry on. I'll run for the IV line, because that's the thing that rips out first. So, and then the next focus would be on the airway, because the line is out within seconds. The airway, you've got a few seconds to react after you've secured the line. So, reversal of a normal reaction. The normal reaction would be go for the airway. I would try to protect the line first. Okay, but there's something else that makes sense. You've got people with epilepsy mostly have carers. They have got people that know them, that are around them when they do get epilepsy. And in my case, although you might not have space in your little dental room or whatever, I would actually want to have that carer there. First, they know what happens when the person gets the epileptic fit. Secondly, they know what to do. And thirdly, it's a pair of hands that gives you a chance to look after your line and the airway. So, and they also, the fact that they are there makes everybody else a lot less stressed. She knows what to do when he gets a fit. And then suddenly your dentist calms down and everybody calms down. So having your carers there. So the immediate reaction would be airway and the line. And then you start looking and trying to control all the movements. So what happens, normally when somebody gets an epileptic fit, there's no monitoring going on. But now you've got a monitor up. So what happens to the SATs? Straight down. What SATs, what saturation is tolerable for how long? If your SATs drop to 70, are you comfortable with that? Before I had this pouch and obstructive airways disease, I was a mountaineer. We were operating, climbing, with backpacks weighing 32 kilos, with SATs of 40. You can actually do physical hard labor with the SATs of 40 if you are fit. For hours. But eventually you need a little bit of supplemental oxygen. So the calmness that needs to come over you when your patient's SATs drop, so that you can think what you're doing and make sure that you're going to save that brain, needs to understand that patients, I'm not talking about people with myocardial infarctions previous and angina and things, but you need to understand that rather do the right thing carefully, slowly and properly than panic about a SATs that's now down to 85. That's practical experience. So rather focus, sit back, take a deep breath and start doing the right thing. I'm not telling you to get patients down to 40. They're not fit mountaineers. That's not what I'm trying to tell you. But what I'm trying to tell you is that if you have a patient that's got a drop in SATs, make sure that you do the right thing. Get the airway sorted out. Get the stuff doing. Calm down. Okay. So now your SATs is 32. Patient is having a convulsion. Are you going to give oxygen? Are you going to fight the whole way down just to get the oxygen? No, because this patient has had 50 previous convulsions episodes with a SATs of 30. You'd rather start calming down yourself and look after that patient properly. Make sure he's not injuring himself. So the mental set that you get when you have a patient with a convulsion is you calm down, the carer calms down, the dentist please calm down, and ask the assistant to run out because she's going to scream. Okay. what would you, and now, yeah. Now we get to treatment. Quite correct. What would you grab from your bag? You're now in a dentist room and you've got your little bag there with your drugs. What would you grab? Midazolam? Propofol? Ketamine? I thought ketamine causes convulsions. Okay, let's have a look. There we have it. Midazolam, you're quite right. I should have asked what dose. So actually reasonably low doses will give you enough treatment to abort the convulsions. Lorazepam, I chose specifically stuff that a typical sedationist would have in his bags. Everybody talks about thiopental. How many of you have got thiopental in your bag? Nobody. Not me, in any case. But we do have propofol, and there's your dose of propofol that would abort most tonic-clonic convulsive episodes. And then comes ketamine. Ketamine in reasonably low doses can abort an attack. But look at that maximum dose that's used in that study that I'm quoting there at the bottom. Pretty high dose. But usually a small dose can abort an attack. But I think in practical terms, Marie is correct. I'll take some midazolam, give a little bit. Now the next question. We've now treated it. The patient has calmed down. Everybody has calmed down. Now are you going to continue with the procedure? Would you? Would you? The tooth has got a hole in it. Now you're going to just fill it up and get out? The throat is open here. The patient had a convulsion. Everybody has calmed down and they're back to normal. You'll carry on. You'll carry on. And I think that's the consensus. The patient has had fits before. You've now sorted it out. Everything has calmed down. Now you just carry on and do the procedure. There's no sense in running away from it. I mean, just do what you need to do and carry on. And that's not the natural reaction. The natural reaction is, whoa, and stop. But that's senseless. Just do what you're doing. He's got to come back. Correct. Good. I think that concludes the questions I wanted to ask, and I'm sorry that I'm doing it a little bit faster, but I don't think we see that many. So let's rather go to questions. Yes? Would you consider giving more drugs? I would go for the drugs that would calm down, reduce the threshold. I would go for the drugs that would make sure that I don't get another fit.
So you change your sedation?
I'll change my drug regimen slightly, yes. Post-operatively, very good question, because that's where they might have another one. And you don't want repeated convulsions in the same patients. So the answer would be what you expect would be the time that your extra dose of midazolam that you've given would give you protection. And would you then, first thing is I'm going to ask, did he actually really take his medication this morning? And if he didn't, I would very much make sure that he gets his medication. But how much protection will you have from your midazolam? How long? 60 minutes? Would you then give a slightly longer acting drug just to cover him till he's completely awake and he can take his normal medication? And that's probably the answer. Peter.
Hi, Vikas. Just on that slide there, Most sedations have got mag sulfate in their bags as well. What's your thoughts on that?
Mag sulfate works wonderful, and it's used in status. I think the discussion is not really about status epilepticus, but you're quite right. You could use mag sulf. But have you actually seen an acute convulsion in a patient that is not in status being stopped with just mag sulf? Unlikely. So I'd still go for my midazolam.
Of the kids that are non-epileptic that developed convulsions intraoperatively, and they were all just purely on ketamine. On a Monday, I had a child for just dental extractions, just gave the kid IM ketamine at 5 milligram per kilo. I had a line in, and within 5 minutes, the kid convulsed. My propofol was drawn up, 2 mils of propofol, and it was gone. So my experience has been that the only drug that triggered off the convulsions was ketamine. And that's when I used pure ketamine and no other drug.
And that was the experience in the past, and that was the reason why people said that ketamine is supposed to be severely epileptogenic. That is the experience of people in the field. But when the research was done, it was proven that ketamine is not on its own. So if you have a situation where you've given ketamine and the patient develops convulsions, you might have to ask, wasn't there other factors involved? But you are quite right. Every single drug that we use causes epileptogenic foci in the brain if you are going to look for it. But at the same time, the same drugs are also used to treat epilepsy because it suppresses the epileptic potential. So it's really a double-edged sword here. And I think what happens is when we use ketofol, we are using a combination that would suppress this situation. And one of the reasons why I stopped using pure ketamine is exactly what you're talking about, and why I'm so happy to use ketofol. I think if you've got an epileptic patient and you give a drug that drops that threshold, you are looking for trouble. But on the other hand, you also know that the drugs that you are using can treat it. So I would rather go for the benzos, which is well known to control the convulsions. So I'm not a big fan of midazolam in general.
But you will give us the benefit of the doubt to say it could very well be your current drugs that change.
Yeah, that's what the same answer to her question is. If I've used a certain combination and I got to stop it and start pushing more towards the benzos, that's what I would do, and propofol, because propofol tends to stop a convulsion extremely fast. Thanks.
Thank you very much. Did you notice there at the bottom, Alan Howard now told me ketamine has been used for status epilepticus. And we've all been raised on the mantra that propofol is not an anti-convulsant agent. So I gather there's a lot about this thing that we still don't know. Ladies and gentlemen, our last speaker, Nicole de Hendricks. She's an anesthesiologist from Tygerberg, a lady who recently relocated from Gauteng. At last you saw the light. And she loves mentoring and she loves tutoring, and she's a consultant at Tygerberg. And she will speak to us on what we all do, sedation for a patient having a procedure under a regional block. The typical patient for a knee replacement, hip replacement that we do a spinal for, how do we sedate them? The floor is yours. Thank you.
Hi, everybody. Thank you so much for having me. All right. Okay, so thank you so much for having me. How many of you guys actually do regional anesthesia? How many of you guys do regional anesthesia for orthopedics? And for labor? Other? Pardon? One moment. Okay, sorry about that. Okay, so we do a lot of regional anesthesia, obviously, in practice, and it's nice to know that we can do things under sedation or not under sedation. There are some procedures, and I'll come to them at the end, where regional anesthesia is pretty much your first choice for the outcomes, healthy outcomes of our patients. So what I want to just go through is just a couple of things that you guys are also familiar with. I feel very privileged to sit in a room where you guys are so experienced as sedation practitioners, much more than I am. I see some familiar old faces as well that I've not seen for many years. So important for patients is a disclaimer for everybody, and this exists in the current guidelines that we have now, is respecting the rights of the patient at all times. A lot of the times patients under regional anesthesia, regional analgesia will ask you one thing: do I have to have this awake? Why? Why do I have to have it awake? Does anyone know any evidence about why it has to be awake? We all go on level 5, expert opinion, anecdotal evidence, not really anything that's been a randomized, double-blinded, controlled trial to say, listen, this is decreased incidence of nerve injury, decreased incidence of LAST or local anesthetic systemic toxicity. We all do this because we've been doing it for many years. But has anyone considered that the patient at risk for myocardial infarction, and now he's very anxious, you've forgotten to give him his pre-med in time, or the ward has, which is usually the case, and you come to theater with a heart rate of 110, freaking out. We've all had patients like that. Sedation techniques, you guys are experts, much more than I am, advanced and simple. A lot of the times for some regional anesthetic procedures where you can only really consider regional technique for certain patients, simple is probably better than not simple. But what do you use? Benzodiazepines are something that everybody's used for a very long time, but there are so many new drugs, and I'm so glad so many of them have been talked about today, and I'm sure yesterday as well. Advanced sedation is what a lot of people do use, myself included, but in this setting with regional anesthetic techniques, most of the time, if not all the time, what's great is that you'll be in a hospital environment, or at least a theater environment, where you'll have access to all 5 standard ASA monitors, and then some, including prepared airway trolley and rescue agents, as well as staff available and trained to assist you in any emergencies or complications. I found these interesting. I found this in a presentation from many years ago, that someone actually looked at the stats of who's giving what and how are they giving it to. A lot of people might be anesthetists, anesthesiologists, medical practitioners with sedation training. The bottom line is everybody is using sedation in terms of simple as well as advanced sedation. Depth of sedation is equally important. A lot of people don't always document the scales that they're using to actually do sedation for procedures. A lot of people don't routinely, myself included, use BIS for advanced sedation, especially moderate to deep level sedation, but maybe it's something to consider. What about sedation endpoints? What do you want? We've had tons of speakers here who've talked about actually very personalized, and I'm going to say level 5 evidenced, sedation points for their own procedures where they know their surgeons, they know their patients well because they've spoken to them, and they know what the outcomes are for that particular surgery at that particular time. And that is important. It's not solely about sedation endpoints from vitals on your screen and from what you know from literature. I've put this up there, but I'm glad to see that most people are using the advanced sedation techniques using actual pumps. Personally, I enjoy TCI pumps for both my remifentanil models as well as my propofol models, and I often use them in combination. I also use pumps, but not so much TCR models for things like dexmedetomidine, but you also do have to know, as spoken about before, how to use these drugs and how to use them especially in combination. A lot of the agents that are talked about in the guidelines are actually talked about at doses far lower than usually supposed to be used, because they mention doses that they want to be safe, especially when used in combination with other agents, because most of us do. Patients come with pre-medications, we give them more, and we want them to go home awake, fully able to comprehend everything, do everything, and safely. So I've put this up here because in the institution that I'm currently in Tygerberg, we often do a lot of sedations using what I've now come to learn as a hoenderpotjie. I wasn't able to call it a hoenderpotjie before, and nobody knew what I was talking about in theatre. But now I know it's a hoenderpotjie or a katpotjie or a chicken foot. And these are actually very handy for the sedations, and I actually put them up routinely for my patients, not just use three-way taps in different combinations. I like the fact that it's an individualized regimen for my fluids, for bolus doses of anything. For example, if you've got seizures, and the other drugs that can run separately and with its own infusion pump. But just bear in mind that if you're running infusions, make sure you have an actual flow saver line that doesn't backflow. That can land you into trouble, especially when you're relying on a still patient where you little bit of titration on the pump makes a difference. If you have a backflow and your pump is bolusing because you've chosen a model, it might be worthwhile not to have it backflow up the line. Okay? I've included some old articles as well, because you can see way back when the Swiss, the rest of the world, including us, we're interested in sedation for regional anesthesia. Regional anesthesia has made significant advances in the last 4 to 10 years, including procedures that we do awake, procedures that we do under general anesthesia, procedures that we do in the brachial plexus, in the lower limb blocks, procedures that we do in and around peripheral nerves, procedures that we do for breast cases. They've made advances in where we can use them. For example, there was recently in the last 5 years an anesthetist who was approached in Johannesburg to do a case that nobody really wanted to touch, an ASA3 patient who was FUBAR, but it was a gentleman who needed a breast surgery. He needed a mastectomy. The anesthetist was a trained regional specialist, at that point in time he had a fellowship, which was great, and he actually had to go and think, though, about what the sedation was that he was going to use in combination with the regional technique to do an awake mastectomy for a man. It was conducted and uneventfully using a variety of paravertebral blocks as well as PEC blocks and adequate sedation and monitoring in a theatre environment where he was ready preoperatively, intraoperatively, and postoperatively for all complications. So we can actually do things, knowing things. This article for Way Back When also talked about all the drugs that we are using more and more these days. For example, remifentanil. But do we need to use drugs like remifentanil or big doses of fentanyl or opioids in a patient where you've actually got a regional anesthetic procedure on board? For example, regional anesthesia, I'm sure you guys have all got experience with different percentages. Me personally, I've done a lot of procedures, and I'll come to some of those in a moment, where I've done them fully awake in patients and with a very little bit of sedation. But as we spoke about in 2 different sessions today, that psychosedation makes a difference. The tone of your voice, the beta frequencies of your voice, holding a hand, which is not always possible, but it's necessary. Okay? We'll come to that in a moment. I've also included this. The Germans were kind enough to, after 2007, start recording all the complications and interesting things they saw using regional anesthetic techniques. Interestingly, they didn't actually find a difference in complication rates for nerve injury. One patient in this whole study actually had a thoracic epidural placed with an actual pleural complication. And interestingly, they didn't see any difference between sedated patients and non-sedated patients. How many of you, for placement of epidural, sedate your patients? I do now, for the anxious patient. I've had 2 in 2 weeks where I've given them a combination of either dexmedetomidine or a bit of fentanyl and dexmedetomidine. Both cases were able to sit up with a little bit of help from the staff in theatre. The epidural went in with no mess, no fuss, because they were difficult. The patient laid down, was still communicating with us fully, and the procedure continued. The patient woke up at the end, no mess, no fuss. You don't have to use textbook doses. You need to understand your drugs, understand the first principles, and use it effectively. The second case where I used the epidural was a bit more complicated in that I got a call from the orthopedic head of department to say, if I don't feel that the case is safe for theatre, we don't have to proceed. So we took a long, hard look at the woman, gave out all the considerations for her, and decided that we were going to try something for her to render her being able to walk when she went home. Of course, it was for a hip. So what we did was we gave her a small bolus dose of dexmedetomidine over a full 20 minutes using an infusion pump, at which point we had a full monitor, including an arterial lineup. Once she settled, which she did, we sat her up. She wasn't very comfortable, even with a fascial plane block. We lay her on her side, the epidural went in, and the procedure went ahead uneventfully. The patient went overnight stay to our post-operative acute care unit, which is really just a monitoring unit, and she went to the ward the next day, and she was fine, and hopefully on her way home to recovery. These things are possible. I had a patient the other day, about 3 days ago, who had a BMI of 60. The patient had 0 neck. When we put any probe on her, most of the nerves were about 5 or 6 centimeters below where we needed to be. The patient was for an elbow ORIF. She was very large, and unfortunately, a simple fall on her rug resulted in her breaking her elbow in a very complex position with a radial head injury. How would you guys have managed that anesthetic technique in terms of sedation, in terms of regional? Any ideas? We also had to think about it for a bit. Introducing the spinal of the arm. So that's what we did. It was difficult. We did it with a 2-man technique, using her sitting up on the bed, using all our monitors on board, and using at that point about a half a mic per kilo of dexmedetomidine, slowly infused over 20 minutes. The patient was calm, she was fully counseled, and we identified the area, which was difficult. We used a high-frequency linear probe, and I urge you to do all your anesthetic regional techniques using combinations of ultrasound these days, as well as what you know of using peripheral nerve techniques, because there's going to become a time where it's going to be difficult, and ultrasound offers that advantage. We are all still learning. Why not learn with the things you know and the things you don't know at the same time? Eventually, we did find a plane where we could actually access her, and while I held the probe and directed the needle, someone else actually administered the drug, and we were able to actually administer a full spinal of her, a full block of her arm using a supraclavicular block, which was difficult, and she then continued under anesthesia, not fully awake, but with a small background infusion of dexmedetomidine. The procedure was difficult from the surgeon's side as well, as expected, and it went off, though, uneventfully. Rather than rendering this woman with a significant obstructive sleep apnea risk, significant airway threaten, significant risk of morbidity and mortality on the table for that procedure, we had conducted something that we felt we should have probably done some kind of study or some kind of statistics, but at that point in time, we wanted the best for our patients and we wanted the best outcome for our patients. Anything is possible. It is possible, okay? There are lots of things that I love to do with regards to my patients for arthroplasty, patients for especially the hips and the knees. I want to know, you guys do a lot of arthroplasty in hips and knees. Most people do. What do you guys do for your patients in terms of general anesthesia or regional? Majority of mine are done under regional. What do you do for your patients with regards to sedation? Do you use simple methods? Do you use fentanyl? Do you use midazolam? I still use it in certain patients. Bear in mind the population of patients that comes for those arthroplasty procedures and the paradoxical reaction to midazolam. I've had a few patients like that in my lifetime, which I regret in angio suite, having ever touched them with 0.25 milligrams of midazolam, not knowing where my flumazenil lived. So what do you guys do? What do you do for a hip? A 59-year-old hip that comes because she's fallen, she's otherwise well, she's a very large woman, she's got some sort of neck if you've ramped her, and the hip is going to be done in the supine position. You've got access, tons of it. She doesn't want to go to sleep at all. You don't want to put her to sleep at all. And there's no post-operative ICU for her at all. What kind of sedation would you use? Yes, Dr. Muller.
I do all of it. And what I do,
Yes.
I use dexmedetomidine.
Love it.
I mix it in at 5 mics more in 15 ml syringe. I draw up, depending on the patient's weight, 5 to 8 micrograms of dexmedetomidine. I combine it with 2 to 2.5 moles of heavy marcaine. I do the spinal block, and I use the remaining dexmedetomidine as my sedation intraoperatively. I've never ever needed to convert to a GA or use a peripheral block. At one stage, the surgeon took 6 hours, and the patient's absolutely fine.
I absolutely love that. My experience with dexmedetomidine using in peripheral nerve blocks or in neuraxials is very limited to pediatrics, but I really, really enjoy that option. And dexmedetomidine for me, since 2018, has been one of my favorite drugs. Not always available, very expensive, and there are other options, but thank you so much for that. Does anyone else use any other options for hips? So I've used other options. I've used propofol as well, using a TCI model, using the Schneider effect site model, where again I've set up the setting that you've actually seen the way the pumps were set up, where I've used 1 milligram of midazolam. I've actually occasionally put lignocaine into the propofol syringe, occasionally anesthetized the patient with some lignocaine in the line, and sometimes occasionally run lignocaine as a separate infusion together with my propofol, not really exceeding between 0.5 and 1.5. You do need to know your patient's weight, and if you don't know their height, you do need to carry a measuring tape. It's a simple tool. Measure the height, you have the weight from the ward. If not, the ward will actually tell you from the bed sometimes what the weight is. I've never had to give any opioids too much for these patients, although I have had significantly older patients where dexmedetomidine, if not available to us in the public sector, was a problem. So where I've had to use small boluses of either fentanyl or sufentanil, but my hesitation for the midazolam was based on all my past experience with very older patients and having paradoxical reactions to the midazolam. Okay. I'm going to propose you some of the strange things that we've had requests for from surgeons. This was by far one of the strangest, and you guys can tell me what you would have come up with, because we tried a variety of techniques in order to manage one that eventually we kind of got round to making a protocol. My original teaching hospital, one of them was Chris Hani Baragwanath Hospital, where our gynecology staff, although not specifically regional, I thought it was an interesting thing. They requested for us that they wanted to do a new and improved procedure called a HIFU, high-frequency ultrasounding of fibroids in women who were young enough and fit enough that wanted to have children a little bit more safely than having a myomectomy or anything like that. Their brief was simple. The patient needed to be prone, awake, but sedated, with her bladder full in a bowl of ice water. So we did. We attempted it. We attempted multiple techniques. What would you guys do? That was the brief. The procedure lasted anywhere between 2 to 4 hours. Prone, sedated but awake, enough that they could communicate. They were given a doorbell in a vat of cold, icy cold water with their bladders fully distended. Any takers? I love it. How would you combine propofol and remifentanil, in this case for HIFU, knowing that brief? When I said the patients had to be sedated but awake, they wanted the patient to be able to tell them certain things. Ma'am, do you feel a burning? Yes or no? Ma'am, do you feel lightning shocks down your leg? Yes or no? Ma'am, you're not allowed to move. Would you? Fantastic. The other thing for that particular patient profile is that we did have to run Sentosanone infusion in the background, so you needed to be aware of your setup as well. You needed one of those wonderboytjies on board because you had multiple things running. Any other takers? So the reason I brought this case into view is because it wasn't just about sedation for these patients. Remifentanil, perfect. Propofol, I love it. However, these patients, after a while, were found to actually have a lot more pain, I think, than was anticipated by either the surgeon or us as anesthesia. So after a while, we all started changing up our regimens until eventually we came to something useful. Analgesia is equally important in these cases. When you're doing regional anesthesia, it's the same. Consider the percentage of drug that you're using in a patient that you're going to be sedating only for a technique. Neuraxials and epidurals make a difference. Obviously, they're very different. But when it comes to regional anesthesia, if you're going to be using a 0.25% or anything less than a 0.375%, consider that your analgesic technique may need to include something with a background of analgesia cover. For example, fentanyl. Consider how you're using the remifentanil at least. Consider how you're using the remifentanil, and consider what kind of drugs you need to use and what kind of combinations you need to use them in. Okay? So what we ended up doing for those cases eventually was we would run, they would come in through the door, I would put up their lines, they would get counseling. Unfortunately, it was arrive in the morning, get into theater that morning, report, took 5 minutes, not a lot. They would get a Pafalgan run. In the Pafalgan would be 4 to 6 milligrams of morphine. They would get a background of something analgesic and some kind of antiemetic. They would get onto the bed, and we either had remifentanil running for a lot of the procedure. Sometimes, yes, with propofol, not always. The patients were well counseled and were given a little doorbell to ring if they had problems, were counseled well enough in advance by the surgeons and anesthesia. Occasionally, we had the option of using dexmedetomidine, which was fantastic but expensive. And that's how we managed it over time. These things are possible, but I think like Dr. Smith mentioned, like Dr. Muller mentioned, you need to take a step back and see what's the requirements of your surgery, what's the requirements of your surgeon, and what kind of patient population and profile do you have. I have not always given sedation to my patients for regional anesthesia, based on everything I had learned and read as a registrar, from the fact that I want my patient awake so that they can tell me if I've pranged a nerve. I want my patient awake enough so that they can tell me if I've given local anesthetic and caused local anesthetic toxicity. That being said, especially for my vascular patients, I'm especially cautious with the concentration and dose I give to those patients who've got a lot of collateral vessels around the areas of nerves. I have seen that present not as convulsions, but as definite onset of local anesthetic systemic toxicity. For my future and for the last year or so, I actually have been sedating my patients for regional anesthesia, sedating them outside the room, in the ward with some kind of pre-med, sedating them as the drip goes in, and sedating them while the procedure is actually happening. But together with all of that, psychosedation, as mentioned so many times before, is important. I've actually tried in a couple of patients for the knees, where again I've used propofol because the block that I used was a neuraxial, and I actually used morphine in that. I've used headphones, just soft headphones and some nice music. It was more than enough for the patient to tolerate the procedure, especially given the fact that a lot of those patients are overweight, very increased BMI, and difficult to manage their airway if you do run into problems. So, with regards to recovery from sedation during regional anesthesia, again, we're lucky in the sense that a lot of these procedures take place in a hospital setting, or in at least a setting where you can actually monitor them afterwards and look at their Aldrich scores, look at their discharge criteria before you send them home. Just be aware that just as you would for your sedated patients, where you want them to be taken home by somebody, you give them all the correct criteria of how to look for and that they're fully reversed and fully awake from their procedures. The same holds true with regional anesthesia together with a sedative on board. If the patient is unable to maintain the leg or the arm, and you haven't maintained for them, the risk of injury is still there. So you do need to have the family or whoever's looking after your patient correctly counseled and appropriate measures in place. Okay, thank you. Is there any questions?
Any questions, ladies and gentlemen? Nicole, thank you very much.
Pleasure. Thank you for having me.
That was a real tour de force. Thank you very much for that. All right, ladies and gentlemen, that brings us to the end of this Congress. Thank you very much for taking the trouble, coming here, traveling here, and all of your contributions. A special word of thanks to Louis Smith. Louis, you've done an excellent job. Thank you. Thank you very much. Right, and then you're free to go, except the exco. They must just stay around for 5 minutes, and then please, before you're free to go, you have to complete this form, please. Peter, do you want the name at the bottom? No. Thank you very much.